يكون خير ان شاء الله. ان شاء الله مصحصحين على The next talk by Dr. Asad Ahmed about complex tibial plateau fracture. Dr. Asad, the floor is yours.
ما شاء الله موضوع مهم ها اوكي سيدي اشتغل and this patient is 6 months after TBS plateau fracture. The video doesn't work, but here he has valgus malalignment. He cannot feel away. He has very stiff knee, and this is his X-ray. And CT scan. What do you think? What has been done? Open internal fixation, but no reduction. Why this happened? So to avoid this complication, this is our learning objective. This is the fracture complexity and the mechanism of injury and define its role in and also we'll discuss the principles of fragment-specific fixation and decide the surgical approach to fracture. We depend on choosing the approach and evaluate the role of one graft substitution for periarticular defect. We know that we have two groups of patients, elderly or young people, and in the elderly the problem with the bony coil, and in the young people problem is soft tissue, high energy trauma, and usually there is and the question only the energy of trauma decide our plan of treatment. Because also we have to ask, is the injury mechanism in terms of direction of the trauma direction? Does this affect our treatment decision? What do you think? Yes. Okay, so as general principle, we know all this is basic. We have to anatomically reduce the articular fragment to support it, and also to have a stable fixation to maintain the alignment and enable early range of motion. Yeah. And also we have to respect the soft tissue. How we respect the soft tissue? Timing the care of the soft tissue, splinting, expect timing, choosing the approach. Okay. And also remember that staged treatment of tibial plateau fracture is much better than expected one. So always don't hesitate to have staged treatment. So for that we want to span scan and plan. Can we keep the external fixator as different treatment? Sometimes yes, because if you have severe soft tissue injury, so you have to take care. And when body expects, it may be the definite fixation. So you may incorporate some percutaneous fixation of the large fragment in case of severe soft tissue injury. And I think we have discussed with anesthetist of the radius. We talk if you can manipulate by wires. This is good idea, if you cannot open. Now the principles of internal fixation, the same. Anatomic reduction, and we have to support the fragment and to have stable fixation. But remember this, we should have fragment specific fixation. And to have specific fragment fixation, so we have to fully understand the 3D morphology of the fracture. And how we understand the fracture, we have different classification, the AO, you know, and also the CHASCA. For a long time we developed on CHASCA classification and planning our treatment. But the new way of thinking, this was by Kong Lu, from China, described in 2010 the 3-column concept. Like you look to the tibia as 3 columns, the medial, the lateral, and the posterior one, and to have a CT scan with 3D reconstruction to know the morphology of the fracture. What 3 columns? You see here the medial one, the lateral, and the posterior divide the medial and the lateral, and there are more classification depending on this 3-column classification. What's the advantage? It gives morphology of the fracture. So we can see which column is fractured, like here the medial, the lateral, and also the posterior, because this is part of the posterior, and also where the depressed fragment. So you make your plan according to this 3D morphology. Is it only just 3D morphology? No, because the 3D morphology gives us idea about the mechanism of fracture. Because you know when we take like fracture reduction, we reverse the mechanism of the joint. Yeah, hyperextension, the rest we do flexion and so on. So when you do the mechanism, know the mechanism of injury, this may affect your treatment plan. So if you have like this, a medial column, this means that it's extension bars. When lateral, this means extension bulges. When anterior, this means hyperextension. And when posterior, this means flexion. So this will give you idea about which column is a fracture, which articular surface we should treat articular defects. And this gives us the details about our fragment-specific fixation. So we got the pattern split where? On the compression side. And on the tension side, what we do? We put like supporting it, smaller plate. Like anyone do osteotomy? With osteotomy, we always try to keep the hinge. If you keep the hinge, it's more stable, allow the patient full weight bearing. So it's the same. If you fix this, this may act as a hinge. So if you put small implant, will make more stable fixation. And also, fragment-specific fixation include drafting of the articular fragment, elevate and draft. And now, again, you can use these plates to bridging what? The metaphyseal comminution. So you use the main pattern split, maybe you make it longer to bridge the metaphyseal comminution. So this depends on the mechanism of injury. Now, how we choose the approach? The biomechanics of fixation. So you want to put the plate posterior, so where you go? You want to put medial, lateral and posterior. So you have to decide the approach. So you may need one approach to fix more than one column. So you have to think of that. Because you cannot do incision everywhere. Yeah? So this approach depends on the biomechanics of fixation. Only that, no, you have to know where is the best articular fragment, so we can go by our approach, have access and elevate it. And also again, the soft tissue. Sometimes make limitation for you. Let's take this example. What you can see. Okay, this is lateral column fracture with depression. And what's the mechanism? Why extension? Why not flexion? Because the circumflex. Okay. Yeah. Well, how you treat? Which approach? Anterolateral approach. So you use the anterolateral approach, and you can do submeniscal approach to see the articular surface. Yeah. Or you can do it arthroscopic assisted if low energy or not high, no soft tissue condition is good. Now this is what happens. Elevation of the fragment, bone substitute, bone graft, and pattern split, and use the screws as round. What do you think about it? Do we need all that for addressing in this? Yeah, you can do different things. You can do several grafting, smaller blade, and so on. Now, you can. How do you manage the bond defect? We can use bond, sometimes from local allograft shapes, or you can use bond substitute. We have used what we call the calcium phosphate cement. Anyone use it? Sure. It was available in Jordan for a short time. It was excellent because it is distributed, and also it become tough, like cortical density. Yes. Okay. Now, which approach? What's here? Which approach?
Probably not CSCT because
CT, Excellent.
the posterior.
Excellent. What do you see from here?
Well, a lateral column for sure with depression and posterior column.
A lateral column or a lateral here debris fragment with intact column? Maybe.
And posterior on the lateral.
Posterior sure.
We see posterior involvement.
This is the CT. You see, the lateral is open. So what type of flexion mechanism? So where you would put the blade?
Posterior. And the approach posterior as well.
Okay, is it good? So in this way, we have to think of this fracture, how to approach. So this is flexion injury. So you go posterior approach, because flexion mechanism, and you can do double blade in case. Look, you see there is medial, medial lateral fragment. So for fragment specific fixation, there is what? Double blade. So this is the way we think of that. Now let's take this. Which type? 4. Medial. So what would you do? Medial blade. Yeah. CT, excellent. Okay. Here an example. This is excision varus. Here an example of the medial fracture, medial side. But take care because this is a special entity of fracture because many times associated with fracture subluxation or dislocation. So you have to be careful. Now the surgeon depends on only Chatzker's classification and did this. What do you think? Is it enough? No. Why? Who said posterior? This is posterior. So this is what? Varus flexion. So you need what? Medial and posterior. He didn't. Yeah, look here. So, okay, this is another one. What's this? Which type of fracture? Varus extension or flexion? You see, it's varus short and flexion because here you see the posterior column. Yeah? So the surgeons depend on the column classification concept, not on the chest. So because chest doesn't give you all the details you need to plan your yeah. So what do you think? Which approach? Stereomedial. Dual. Who said dual? Which type? Anterolateral, you need it? Media and posterior. So I'll tell you. Look here. This is varus flexion, yeah. And look here. What do you have? You have the blessed fragment, and we said that for the approach you have to reach this fragment, and also you have posterior column. So what would you do? So we have to go posteromedial, and we have to go to fix the fragment. How? We cannot reach posteromedial. So dual approach, anterior approach, midline, and you go posteromedial approach to have distance between the skin, yeah, between incision. And here, you look, this is the midline, and this is the anterior window, and fracture. And from here, you can manipulate the small fragment. And here, you see this is the posteromedial approach. I think it's called by Dr. Hoffman. Okay, now this is the fixation. Okay, you accept that? Happy? What do you think? Excellent. Now, let's take this fracture. Which column fracture? We don't have the CT, but the posterior column is intact. So what's this? Bicolumn. How would you plan fixation? Medial and lateral dual plate. Okay, here's the fixation. No posterior fracture. And this is the incision. Should be away from each other, and when the soft tissue condition, okay, yeah? This one. Which approach? First, we have to know what's the mechanism, yeah? We agree? And where is the depressed fragment we need to measure? And here, you see, where is the compression side? Medial. Where is the tension side? Lateral. Is the involved or not? We need CT scan. This is the CT. Involved or not? Yeah, it's involved. And you see here, there's fragment missing here. It's lateral. You see, this is fragment missing here. Here it goes lateral. So how we decide the approach? The fit. So this is, you need posterior approach to fix both, and also you need anterior. Yes, here, you see. This is posterior, fix the medial one and posterior lateral one, and for the lateral column, lateral approach. This is the, and this is the last case. This is a flexion valgus injury. So the comminution is more here, look here. It's very comminuted. So when you decide the treatment, you should have patellacing here, and the medial column, medial side. So which approach? Medial, okay, medial approach. And lateral, how you assess this and this? Extend the lateral approach, exactly. And you see here, either do fibular osteotomy and you fix it later, and you see here, the patellacing plate posterior, lateral, posterior, and the medial side. And or you can Frosch approach, which is you have two windows can reach the lateral and posterior. So take home message, fully understanding of the fracture is essential in deciding and making treatment plan. And CT scan will help you to assess the complexity of the fracture. 3D classification allows assessment of the injury mechanism, and by that you can plan fragment-specific fixation in terms of patellus plate for the compression side, supporting plate for retention side, and rafting screw for the articular fragment. And you see the approach, you can decide by the biomechanics of fixation and plate position, the articular reduction, and also the soft tissue. Thank you.
Our tibial fracture, Dr. Yazan, please. We are short of time.